Coronal Polishing by Autumn Givens, RDH. Here are the objectives for the presentation. By the end of the course, students will be able to recall the different types of polish between extra fine, fine, medium, and coarse polish. By the end of the course, students will be able to analyze what patients are candidates for coronal polishing and which ones have contraindications. By the end of the course, students will be able to set up the prophy angle on the slow speed straight handpiece. By the end of the course, students will be able to explain to a patient that does not have contraindications for coronal polishing why they are a candidate for it. By the end of the course, students will be able to assess the successfulness of coronal polishing and the areas that need improvement. Do you all remember the various flavors of polish your hygienist offered you when you were a kid? What was your favorite? Mine was cotton candy, but another second favorite of mine was cinnamon. What is coronal polishing? Coronal polishing is a part of the prophylactic procedure that has the goal of creating a glossy outer layer, reducing dental plaque and extrinsic stains, and managing local irritation through plaque removal. What is an extrinsic stain? Extrinsic stains come in many colors with different etiologies. Brown stain is typically caused by tobacco, tea, coffee, wine, soy sauce, or chlorhexidine. Black line stain is usually from iron, silver, or manganese. Green stain is typically caused by copper and nickel. And then orange stains are caused by chromogenic bacteria. In the upper picture, this depicts brown stain. You can see it along the gingival margin. And in the picture below it, this is a black line stain in the interproximal of these teeth. How does coronal polishing remove stain and plaque? Abrasive ingredients are present in coronal polish. These abrasive ingredients thin out staining layers. Varying particle sizes dictate the abrasiveness of polish. Particles that have larger, sharper shape have higher stain and plaque removing power. This is known as coarse polish. Particles that have a smaller spherical shape are less abrasive and therefore are more challenging to remove stain. This is known as fine polish. What are the ingredients in a typical pumice coronal polish? The abrasive agent is pumice. The active ingredients are fluoride, xylitol, calcium phosphate, and calcium thiosilicate. There are binders and humectants present. These consist of glycerin, sodium carboxyl methyl cellulose, and propylene glycol. And then there's other ingredients. There's flavoring agents, titanium oxide for different colors, sodium saccharin for a sweetener, and then purified water. Who is indicated for coronal polishing? Individuals that are indicated include those with extrinsic stains, furcation involvement, those with orthodontic brackets, and those with plaque buildup. What are the contraindications for coronal polishing? Enamel hypoplasia, hypomineralization, dentogenous imperfecta, amelogenous imperfecta, dental fluorosis, tetracycline stain, newly erupted teeth, gingival recession, COPD, and then after you complete a scaling and root planing procedure. What is enamel hypoplasia? It is a condition in which the enamel does not develop properly. This lack of development causes the outer layer of the tooth structure, the enamel, to be thin or missing. Due to the compromised integrity of this outer layer, coronal polish can cause more wear on this thin or missing layer, making it a contraindication. Hypomineralization is a developmental defect that causes the enamel to have lessened mineral content. This lessened mineral content causes the enamel to be porous, softened, and discolored. Due to the compromised quality, coronal polishing is contraindicated due to the polish causing micro wear on the teeth. Dentogenesis imperfecta is an inherited developmental disorder which causes malformed dentin, which is the layer that lies underneath the enamel. This can cause tooth discoloration and weakness. Due to this weakened structure, the coronal polish is not recommended due to, again, causing that micro wear on the layer. Amelogenesis imperfecta is also a genetic disorder that impacts the enamel formation, which is the outer layer of the tooth. This causes the teeth to look thin and discolored, and they are extra prone to cavities and breakage. Due to this thin structure, coronal polishing is not recommended due to, again, that compromised structure that is more susceptible to wear from abrasive agents. Dental fluorosis is a cosmetic condition caused by excess intake of fluoride. It causes white dots, lines, or streaks on the enamel, and it can also look pitted and brown in severe cases. Due to dental fluorosis being an intrinsic stain, so inside of the tooth structure, coronal polishing would not be effective. Coronal polishing is only effective for extrinsic stains, which is on top of the enamel, but since this is in the enamel, it is ineffective at removing this discoloration. Tetracycline stain is an intrinsic stain caused by the ingestion of antibiotic tetracycline. Tetracycline bonds to the calcium ions in the enamel and causes them to be brown or gray with discoloration. Due to these stains being intrinsic, coronal polishing is, again, ineffective for stains that are inside of the tooth structure. Newly eruptive teeth are contraindicated for coronal polishing. Adult teeth to begin to erupt around age 6, and that is when the primary teeth begin to shed. These newly eruptive teeth have a large pulp that is large and vulnerable. Heating up this pulp through coronal polishing is not recommended to avoid pulpitis or death to the pulp inside of the tooth. Gingival recession is the process in which gingival tissues move apically to the gingival margin from the gingival margin, exposing the dentin layer underneath. This exposed dentin layer is thin, so using abrasive agents from coronal polish is not recommended to limit the wear on these vulnerable surfaces. Coronal polishing is not recommended after scaling and root planing as well. Because of the gingival pockets that get widened after removing the hard buildup under the gingival tissues after scaling and root planing, abrasive agents can get into these opened pockets, and it can impact healing after non-surgical periodontal therapy. And after you have that procedure, you want to do as much as possible to try to make healing as easy as possible, and having these abrasive agents in the pockets makes it very challenging to heal up. COPD, or chronic obstructive pulmonary disease, is a condition characterized by breathing issues, coughing, and excessive mucus production. Due to the production of aerosols caused through coronal polishing, it is contraindicated for those with COPD to avoid aggravating their condition. Does the abrasive action cause enamel wear? It has been indicated that over-polishing the outer structures can cause wear on the enamel. Up to 4 micrometers of the tooth surface can be removed in a 30-second polishing procedure. The idea of selective polishing comes up to try to prevent this wear or manage it as best as possible. The idea of selective polishing is that the only teeth that have plaque buildup or extrinsic stains should be coronally polished, and the teeth that are free of stain and plaque should not be polished and should only be derided with ultrasonic scalers and regular hand scalers. So how do you analyze if your coronal polishing was effective? An application of a disclosing agent prior to coronal polishing can highlight the remaining plaque. Visual evaluation for extrinsic stain and plaque removal can be used. Before and after photos can also be used, and the use of an explorer along the gingival margin and interproximal surfaces can evaluate if there is still plaque left over after coronal polishing is completed. So let's look at a couple of cases for effectiveness. So let's look at the picture here. A hygienist uses a disclosing agent prior to polishing. After she completed the polishing, this photo is taken. Does it look like the coronal polishing was completed to 100% successfulness? Do you notice the pink in the mesial, facial, and distal surfaces? Coronal polishing was not completed to 100% effectiveness. Disclosing a solution is a helpful tool to analyze effectiveness, and then it can also help with remediation. So looking back at this picture, the hygienist would know where to go back to because it's all highlighted in pink. So she needs to focus maybe on the interproximal surfaces a little bit more. Another case to look at, a patient presents to the clinic with heavy stain. A hygienist completes a prophylactic cleaning with coronal polishing. This is the after photo here on the right side. What technique did she use to evaluate how effective her coronal polishing was when looking at the extrinsic stain? The hygienist used before and after photography, as well as visual examination to evaluate the effectiveness of coronal polishing. After these techniques were used, the hygienist was able to remediate and complete stain removal. What are the parts of rubber cup polishing setup? There is a handpiece, prophy cup, polishing agent, and safety equipment. The polishing handpiece. There are two different options. First is the use of a straight handpiece or contra-angle handpiece that is attached to an air or electric-driven dental unit. There's also a handheld handpiece that can relieve stain and makes rotation of the prophy angle easier in comparison to the handpiece, the corded handpiece. And the handheld one can also reduce arm strain as well because the tubes aren't really tying it down. The prophy cup, they are soft silicone angled cups used to pick up polishing agent and complete coronal polishing. There are various firmness that can aid in supra and subgingival polishing. The prophy brush angles can be used on areas with brackets or furcation involvement because the brush reaches into these different angles of the tooth structure and of the brackets to help get things cleaned up. Then you need the polishing agent. The polishing agent has various coarseness, flavors, and benefits to them. The safety equipment needed is a patient bib, patient safety goggles, proper PPE for the operator, including mask, gloves, goggles, and long sleeves. Coronal polishing infection control is a very important part because coronal polishing causes aerosol. So asepsis is really a vital part of the successfulness of coronal polishing. Use of proper PPE for the clinician is vital for our safety. Slow speed handpiece or handheld polishing sheath must be sterilized in between every patient to limit that contact from one patient's germs to another. Surface disinfectant through an EPA registered disinfection should be used between every patient. Managing aerosols produced by the handpiece can also help manage this through the use of the HVE or the high volume evacuator to help suck up any of the aerosol. Use of disposable prophy angles, saliva ejectors, high volume evacuators, and polishing cups ensures patient and clinician safety. This is a video on the setup and an introduction to the technique of polishing. It is time to do an activity. So for this activity, we're going to get into small groups and practice setting up the handheld polishing handpiece. Now that that is complete, we can get into the technique. So after you have it all set up, you're going to collect the prophy paste into the polishing cup. This can be done either with the prophy angle being turned on or off. Quicker pickup can be completed by turning on the polishing handpiece. Position the rubber cup flush to the tooth surface. Apply light pressure enough to flare the cup into the interproximal surfaces. Use a lowercase m motion for the upper teeth and a lowercase w motion on the lower teeth. Ensure that the occlusal surfaces are polished as well. To avoid excess heat from prolonged pressure with the high speed, this can heat up the pulp. Even though you are not polishing teeth that are newly erupted, since that has the large pulp, even on regular adult teeth that are not newly erupted, it is important to not heat up that pulp as well. And by doing this, you want to only spend about 3 seconds on each tooth. Do not up-polish the exposed dentin, and when polishing is complete, rinse thoroughly with water and the saliva ejector, or if you have the Relief or an HVE, you can use that as well to help vacuum up everything. The next activity is practicing on the typodont. So after you successfully complete setup with the polishing handpiece, it is time to pull out the typodont. Practice motions initially without paste. Evaluate how different pressure makes the prophy cup flare more or less. When you are ready for instructor feedback, come up and you'll get the polishing paste and you will complete coronal polishing completely on the typodont. Here are my citations.